everyone, and welcome to the COVID-19 Public Health Action webinar, COVID-19 Impact on Native Hawaiian and Pacific Islander Communities. My name is Steph Moyer, and I'm the Community Initiatives and Training Coordinator for the Hawaii Public Health Institute. Before we get started, I just want to go over a few Zoom housekeeping. For all questions, please be sure to utilize the chat box or the question and answers box located at the bottom of your screen. We will not be offering continuing education credits for this webinar series. And lastly, all webinars are recorded and will be posted to the Hawaii Public Health Training Huli's YouTube channel. It is my honor to introduce you to our moderator and guest speakers for today. Dr. Joseph Keawe Aimoku Kaholokula is Professor and Chair of Native Hawaiian Health in the John A. Burns School of Medicine at the University of Hawaii at Manoa, and a licensed clinical psychologist. His research involves developing community-based and culturally relevant health promotion programs to address diabetes and cardiovascular disease inequities in Native Hawaiians and Pacific Islanders using community-based participatory research approaches. His research also examines how biological, psychological, and sociocultural factors interplay to affect their risk for and management of chronic diseases. His work has had an impact on the local, regional, and national levels to bring systemic improvements to healthcare delivery, clinical outcomes, and policy through community-based research efforts. He has a strong commitment to achieving health equity and improving the health of Indigenous communities, which are reflected in his service on the national level as past chair for the Intervention Research to Improve Native American Health Network, and his recent appointment to the National Advisory Council on Minority Health and Health Disparities. On a local level, he serves and has served on boards of organizations with the mission to improve population and Native Hawaiian health to include the Queen's Health Systems, Hawaii Public Health Institute, and Papaola Lokahi Native Hawaiian Health Board. As a Native Hawaiian, he is passionate about improving the health of Native Hawaiians and Pacific Islanders and has made a lifelong commitment to improving their social and cultural determinants of health. Our first guest speaker today is Dr. Reynold Samoa. Dr. Samoa is a clinical research endocrinologist. Currently, he is an assistant clinical professor at the City of Hope Medical Center in Duarte, California. Dr. Reynold Samoa received his medical degree from the University of Washington and completed his adult endocrinology fellowship at the Los Angeles County University of Southern California. His primary major area of research includes modifying insulin resistance to prevent chronic disease or improving chronic disease management such as diabetes and cancer via individualizing and culturally tailoring lifestyle modification approaches in vulnerable populations such as Pacific Islanders and cancer survivors. He is currently the clinical lead for the National Pacific Islander COVID-19 response team. Last but not least, I'd like to introduce you to Sheri Daniels. In April 2016, Dr. Daniels was appointed Executive Director of Papaola Lokahi, the organization charged by the United States Congress with administrative oversight of the Native Hawaiian Healthcare Improvement Act. In this role, she leads efforts in developing policy strategies related to health improvement for Native Hawaiians and their families at the local, state, and federal level. Dr. Daniels has also played a pivotal role in the development of internal policies related to the accountability of the Native Hawaiian healthcare systems to their individual island communities. She is also the chairperson of Na Limahana o Lonopuha, the Native Hawaiian Health Consortium, an integrated network of leading senior executives and healthcare providers. Together, consortium members propose progressive models of culture and research-based methods in implementing prevention and treatment programs focused on systemic outcomes among various levels of Native Hawaiian health and wellness. So without further ado, I'd like to turn it over to Keawe.
Hello, Stephanie. I appreciate those introductions. I'm also honored to be the moderator for this panel with two esteemed panelists who are truly experts in Native Hawaiian Pacific Islander health. Going forward, I want to stay, I'm just going to use the term Pacific Islanders out of respect to show unity across all groups, all populations of Pacific Islanders across the United States. So from here on, Native Hawaiians will be included in the Pacific Islander terms that I use in moderating this panel. I just want to set the stage for our speakers and let everyone know that, you know, early on in this COVID-19 crisis, the United Nations warned all countries that there would be a disproportionate impact on indigenous communities across the world because of underlying and pre-existing health inequities and inequities in the social determinants of health that place our communities at greater risk for infection and severe symptoms if infected. The United States public health leadership and officials here also warned of the same thing amongst our indigenous peoples. However, Native Hawaiian and Pacific Islanders were initially left out of that conversation. And as we've come to know, Native Hawaiian and Pacific Islanders, across the Western states show higher numbers of positive cases with COVID, making it a public health imperative for us. So I would like to start off first by directing a question to Dr. Samoa. There is now data from several Western states, including Hawaii, showing that Pacific Islanders have the highest rate of COVID-19 positive cases, and where data are available and reported, higher hospitalization rates. Can you speak to what the data is telling us or not telling us? In other words, are the data useful for us to fully understand the magnitude of this issue?
I think the data definitely shows the disproportionate impact COVID-19 has on Pacific Island communities.
Dr. Samoa, maybe we can go to the next slide. I'll ask our slide person to advance it for you. Sorry
Sure.
about that on the slide.
Yeah, and so the disproportionate rates of disease, confirmed diseases and hospitalizations is seen in Hawaii, but is also seen in Washington State, in King County, in Oregon, in California, primarily Los Angeles County, Utah, Arkansas, Clark County, Nevada, Colorado. You know, I can go on. And I think why you're seeing it in these areas is, one, these are the areas that are actually disaggregating their data. So although it's demonstrating a disproportionate impact, I don't think it by any means tells you the full scope of what's happening to our communities across the country because of the problem with data. There's many reasons for that, and you know, I'll wait for later on in the conversation to talk about what those obstacles are. What's very striking to me is that this is primarily a Pacific Islander U.S. problem. Our brothers and sisters in the Pacific, in New Zealand, in Samoa, in American Samoa, the Republic of the Marshall Islands, Federated States of Micronesia, they're all experiencing very low rates of disease. And many of them don't have a confirmed case of COVID yet. Why is that really important? Well, we are genetically identical. We have almost the same socioeconomic class. We have the same prevalence of chronic disease. So you can try to make the argument that there's a predisposition or that there's something else going on. But if it's not seen in cohorts across the ocean, then that means there's something different about how Pacific Islanders have been facing the disease in the U.S. compared to other parts of the world, you know. And so as we talk about what we can do, highlighting how the different approaches, like the difference between how countries have approached it, I think is going to be paramount to us changing those numbers.
Dr. Samoa, that's an excellent point and distinction you made, comparing the Pacific Islanders in the U.S. to our cousins out in the larger Pacific, and that is a uniquely U.S. issue for us as Pacific Islanders. You know, Dr. Daniels, on the same lines as far as data, are we having similar? Are you seeing similar concerns or issues in the data being captured? Do you agree with Dr. Samoa's assessment?
I definitely do. I think what we're seeing in terms of data is how it's collected, how we're using it to show our case. Here in Hawaii, if you go to the Department of Health's website, which is where they direct you, they're collecting NHPI data, similar to what you're seeing on the slide, but they're also collecting 2 or more races. Well, we know in our communities, just Native Hawaiians is pretty significant to our population. Well, we add in our Pacific Islander cousins and all of those, that's a very large percentage of our communities, of our state. And so that's not really accurately captured. And I think that's important, because if we're not collecting data in a manner across not only the Department of Health, but in other state agencies, if the state isn't collecting the data, it's hard to compare it to other states and what's happening in other parts of the country, as well as the larger ocean. So that's a real big piece, is how are we collecting the data? Are we collecting it in a way that shows our communities? And then next off of that is the data disaggregated? Not that we want to separate ourselves, but we want to be clear when we're talking about the impacts of our communities. What is that looking like in those pockets? And so I think, when we talk about Hawaii data, yes, if you go to the website, you can see it, it's on a bar chart, but then you need to ask the further question is it being collected consistently across everything, or is it only for certain cases? And in Hawaii, we're only collecting that data on confirmed cases. So, people have been asking, what about those that get tested? All of those, no, they're not being tested. And we also know that the numbers that are being collected and that's posted are statewide. So we can't break it down by counties, which is really important, because some counties have a larger percentage of our communities. So we want to look at that, because that information is going to help guide us in as we move towards the recovery and resiliency pieces.
Mahalo for that. And to your point, it sounds like in Hawaii, we may be underestimating the numbers of Pacific Islanders who may have positive cases, because they're not considering those of mixed ethnic ancestry.
Correct.
Thank you so much for shedding light on that. I think that's an important issue. Dr. Samoa, and back to you. I don't want to drive this conversation too much, but I'll just throw this question out, but you can take it where you want to, as well as you, Dr. Daniels. But I know a lot of our participants are wondering, what are the drivers? And you mentioned this, Dr. Samoa, that it's not genetic predisposition and it's not a biological process entirely, because there's quite a difference between Pacific Islanders in the US versus those in the larger Pacific. So obviously there's other drivers or underlying issues. Could you help educate us on that, some of those issues?
Oh, how much time we got? So, there's a historical lack of access that Pacific Island communities already faced before the pandemic. So you have a group that is already somewhat distrustful of medical facilities. And so the numbers that I'm worried about is the numbers that are getting missed because we're not getting tested. These numbers are high, but I would hazard a guess that most of these cases are identified because they're presenting to the hospital, and those that don't, either they're too afraid to come in, or they don't feel like they're sick enough to come in just yet, they're not getting picked up, and so that's really important when you're talking about contact tracing and how do you stop the disease from spreading. The predispositions. So besides the lack of access, we've already shown that, or there's already reports that show that chronic disease, pre-existing chronic diseases such as diabetes, cancer, predisposes patients with COVID-19 to a higher mortality risk. So there's report upon report in different pockets around the country that shows that Pacific Islanders have the highest rates of these chronic diseases. So that predisposes us right there as well. If you look at the slide there with California, the percentage of deaths, the California in Los Angeles County, the death rate in Pacific Islanders, or if I refer to the data, I'll refer to Native Hawaiian Pacific Islands because that's the classification. The death rate in NHPIs is 12 times that of the white population. It is 7 times higher than the Latino Hispanic group, and it's 5 times higher than the African American group. So if that's sort of the endpoint of this high prevalence of chronic disease and our susceptibility to a negative outcome. Some of the other reasons that we're predisposed, we have a high percentage of essential workers, and so we're overrepresented in occupations such as nursing home attendants, security, airport security, food service. And so you can see how if a high percentage of our essential workers are at risk, then everybody that comes in contact with that essential workers is at risk too. So part of our push to try to protect our communities has to extend into protection of these essential workforce. I think that those are the main reasons why we're seeing a predisposition here in the U.S. And so I think it's worth noting that the approaches by different governments that have similar profiles in their Pacific Island communities can help protect those vulnerable communities from the impact of COVID-19. And New Zealand being one of those places that I'll reference. And when it's not there, when you're not getting these essential strategies implemented in places to protect vulnerable communities, you're going to see that the chinks in our public health systems in the armor, if you will, to help protect communities. It's not very good before, and it gets highlighted when a pandemic arises. And so, I don't think it's any secret to anyone that the numbers that we're seeing is a failure of response by the our current medical system.
Mahalo, Dr. Samoa. Yeah, couldn't agree with you more. These pre-existing inequities are really driving the COVID-19 inequities we're seeing, and the access issue is a huge issue for our communities. Not to mention, many of our people are on Medicaid or Medicare that often delay treatment or access, and also the range of services provided. Since we're on you, Dr. Samoa, I know you're the leader, the head of the National Pacific Islander COVID-19 response team, working with several states as well as Hawaii. And I know the next couple of slides are really speaking to some of the strategies and foci of your group. You want to share with us what's happening in your communities?
Sure. So when I was initially told about the, can we go to slide 3? When I was initially told about the numbers in mid-April, I had recently just recovered from COVID-19. And so, my stake in this was to figure out, okay, were the bad numbers that we were getting out of California, were they just a California issue, or was this happening to Pacific Island communities in other places? So the main objective with our response team is to decrease the infection rate in Pacific Islanders, but also to decrease the death rate, but also to decrease the burden, because there is burden that's incurred by families from COVID-19 that doesn't necessarily directly have to do with the infection and the death rates. So just like a true Pacific Islander, I reached out to the community and see what was going on there. And so if you can go to the next slide. The first group that reached back was King County in Washington. And they immediately said that the NHPIs had the highest rate of disease there. And the highest rate of hospitalizations. And at that time, there wasn't a lot of data on death rates that was disaggregated. The other, Utah was able to report that they had the second highest, but they were afraid that their rates were climbing fast. And then there were other groups that have a fair amount of Pacific Islanders that were worried but had no data yet. And so one of the things we had to do as a region was to standardize our approach to get data. You know, what were you asking for and how would you ask it? So our group put together a national group to help share our technical assistance. And so when Oregon needed help with talking to their public health about getting their disaggregated data, we brought epidemiologists from outside the region. We brought clinical people like myself to help them talk to the county. And then their county talked to their state. And lo and behold, 2 days later, their reports showed the same thing as the other regions. At the time, LA County had not reported. It was a California number that was being publicized. And the community went to LA County and said, you have the highest amount besides Hawaii of Pacific Islanders. You need to disaggregate your data and report it. And to LA County's credit, they moved quickly and was able to report. And their numbers are astronomically high. You know? And so this data that comes out does not come about because people are looking at it and reporting them readily. This is done on the backs of community advocates going to these counties and saying, you need to look at us. We are a traditionally invisible community, and we need our numbers to help protect our people. So understanding that this data was just one aspect of it, can I go to the next slide? We realized that other countries had specific strategies that they implemented. So the team, we combed through every publication that was used by countries that are successfully combating COVID-19. So we looked at Taiwan's strategy, we looked at South Korea's strategy, we looked at Iceland, we looked at Germany, and we noticed that there were common themes in their approaches. And we took out all the initiatives that we can implement here in the US and separated them into categories. And then as you can see, these are the categories up here. And some of them are buzzwords now, like testing, contact tracing. Safe shelter is the ability to quarantine. Social support is the support services needed for people to stay in place. Health messaging is public health information to spread behaviors that can help reduce transmission. And then of course, supporting that with policy and resources. And then the main purpose of the national response team is to support regional effort. Let us be very clear. There is no national strategy. I'm not aware of a national communication that shows us how to beat COVID-19. Most of this is done on the backs of local public health departments. So our work helps inform our community to advocate at that level. Can you go to the next slide? So this is our ecosystem that we're using for the national response team and how we support regional efforts. As you can see, the strategy is separated in the top line, and what the regional team provides is on the second line. Technical assistance goes from everything from letter writing to epidemiological support, data analyses, clinical recommendations. And then we're also implementing a community health worker program to be an adjunct to these surveillance processes like contact tracing. And that requires training and certification as well as standardization of processes. The group, as a couple of us here are already on, we share resources. And so we've already shared our data team to help support the local, our regional approaches. And we also communicate best practices because there are some champions out there that are doing some amazing work. One of the things we're realizing is it takes forever if you reinvent the wheel. So we try to facilitate regions in improving their approach by sharing these best practices. And then at the regional is where all the work happens. This is where we're boots on the ground, where we do our networking and we also do our outreach. So we'll talk a little bit about the community health worker program in just a sec. Some of the other networks that we're putting to help us in conjunction with our national strategy is the faith-based network. We know that a lot of our Pacific Islanders subscribe to a certain faith, and they're very diverse. And so trying to gather them into one directory, if you will, a Rolodex, to help facilitate the transmission of our health information in language. So in Samoan, Hawaiian, Tongan, Marshallese, is how we're going to approach this. And so we have the faith-based network teaming up with our media group that is primarily comprised of podcasters. And we are set out to do weekly updates in language to help update the community on weekly statistics in regards to COVID-19 and Pacific communities, the latest health recommendations, but more importantly, what services are available to the communities, such as where the testing sites are, where you can who you can contact for social support services, and things of that nature. And then there are some shared resources that the national team is helping develop, so it facilitates our ability to communicate not just with ourselves, but with the county programs and the state programs. And so the brown pages, because lack of a better name, is our resource directory. And so that's where, in the midst of trying to build an electronic, easy to use yellow pages, if you will, but Pacific Island services. And so that and developing this data warehouse where we can facilitate sharing information in regards to our data with not just each other, but like we said, with government officials as well, to help facilitate these efforts. I'm going to stop there because I feel like I'm talking too long. And so we can save whatever people need for questions. Otherwise, Kiave, if you want to.
Well, mahalo, Dr. Samoa. Excellent work. I mean, really, you folks have been the example for us here in Hawaii and strong supporters and collaborators on our efforts. I guess with that, I'm going to turn it over to Dr. Daniels, who is also at the forefront of the Hawaii efforts in forming a response team locally here to join you folks in this effort, as well as an endeavor that's certainly with other community leaders from our Pacific Islander communities. Dr. Daniels, you want to share with everyone what's going on and parallel to what Dr. Samoa just presented?
Sure. I do want to just kind of step back a little bit and add to Dr. Samoa's comments about underlying issues. I think it's really fair to say that for many of our communities, the cultural practices also play a role in how we've managed our cases, because oftentimes our essential workers or our families are coming home to larger households. We have multi-generational households. So the exposure is greater, right? So we have a higher chance to create clusters. And so I think that's really important to recognize, is that we are, part of our cultural practices, but also tied to socioeconomics, right? The distancing. For many of our kupuna, many in our communities, it's really hard to have that practice of social distancing that doesn't seem natural. And so how do we help continue to educate our community around that? I know I've heard stories where, people going to funerals, how do you create that distancing? It's really hard. And so I think that's things that we want to kind of throw out there, is also playing a role in that, but also needing the resources. And I'm sure, everybody will say resources, but I think it's targeted resources so that we can help communities understand some of these new behavioral things that we need to start engaging in. So those are two pieces I just wanted to kind of add on to Dr. Samoa's comments. But in terms of what's happening here in Hawaii, yesterday we launched the Native Hawaiian and Pacific Islanders Hawaii COVID-19 response team. And it really is about response, recovery, resiliency. I know we've all watched the news and some of the plans that Hawaii has laid out in terms of reopening and the next steps and what phases we're on. But really, we wanted to take this opportunity really looking at what was happening on the national level and the regions across the United States of, well, we need to be driving our bus to make sure that as Pacific Islander communities, that we have a voice. I think the data is just one opportunity to infuse change, but what we're seeing is, there's opportunity to look at economic recovery, to look at the social determinants of health and cultural health and what that means moving forward. I think we've seen many things on social media around what's happening. I think there's potentially confusion in communities because there's so much information. And so part of the role of our response team is to create opportunities, further webinars, other things that we can educate our lahui, our communities on what's happening so that we can provide a mechanism for information, because we know our communities do better when they understand and the information is readily available, not only for them, but for the workers who are the boots on the ground. And so the response team actually invited both Native Hawaiian and Pacific Islander partners, not only the boots on the ground, but those in policy positions in other organizations to look at the economic driving of our state. So really trying to get a broader sense as we look at this health pandemic, that we realize that health is a component, but we also know there's other factors and drivers that we need to be aware of as well. And so taking the national model and really making it ours is what this team is looking at. And so our team has a steering committee. We have 2 sub-teams as well as committee work. So the work groups, and those are the ones that we're looking around the testing, the contact tracing, the isolation. We're looking at data. We're looking at the recovery process. We're looking at how we can have a voice around policy, because we understand that even though this is happening right now, that we need to be, we need to have the forethought to plan ahead and to have a seat at the table. And I think that's really important, that, we've always wanted to have a voice and a seat, and this is giving us the opportunity, unfortunately. But if we don't take a shot at it and do the work, we're not going to see the results. And I think there's things that have been codified in commitment for Native Hawaiians with Hawaii, but also with the US and our Pacific Islander cousins. And so really looking at that and reminding those local government officials what it is that we need to look at, the big picture, not just in silos. I think we need to move away from the silo mentality and operating and really become a collective, cohesive voice in how we move forward. And I think the response team has also been looking at other areas of our community because it is a collective movement. We're seeing that there are groups forming around the economic stabilities. How do we look at the state's economics? And all of those pieces. So it's all of these factors that are coming together and really looking at the national model that Dr. Samoa and his team has really kind of laid out for us. And we're able to look at other states that have, similar demographics and look at some of the work that they've been doing.
Mahalo, Dr. Daniels. You actually touch on, both you and Dr. Samoa touch on several issues that I think important for us to know, and perhaps both of you can speak to, and that's really the resiliency of our communities. From the very beginning here in Hawaii, I know for a fact that our Native Hawaiian community were some of the first ones to come out with concerts over Facebook, over Zoom, to help our communities get through the shelter-in-place orders, to make sure everybody was healthy and well and connected with each other. Some examples is from Kanaiokana, with their Lea Nui Nui series and He Hue Vaiola series that they do every week to share. And some of this really returning our people back to our cultural practices, giving the opportunities to engage in things while at home, but also sharing important information. But I want to more of you guys' thoughts, you know, around the opportunities. I mean, it's an unfortunate situation we're in, but for the future and for addressing our health inequities and advancing our agenda in our communities, what do you see as opportunities around this tragedy? I know locally we're talking about Aloha Aina-based economy systems, rethinking our over-reliance on tourism is really felt at this time, and diversifying our economic systems here in Hawaii. But what do you folks see as the opportunities that lay ahead of us that we should take advantage of?
Well, I think for us here in Hawaii, yes, Calvin, you mentioned the Aloha Aina Futures Declaration that's come out, this kind of movement. But I think it's educating and continually providing opportunities for our community to understand what's happening so that they are more involved in the choices that they make in standing up for how they want to see the future of Hawaii roll out. You know, I think this has brought opportunities for partners to come together to create really true partnerships. I think over the years, we've always said we collaborate, we partner. Sure, maybe. In some situations, definitely. But this really brings us together with a very clear common goal. And so the response team specifically, we've had over 30 organizations come to our launch. It's an evolving group. We are in no way being an inclusive group. It's very open because we want to make sure that those that are helping our communities, our Pacific Islander communities, have an opportunity to share, to bring voice, to bring concerns, to bring best practice models and ideas to the table. But it's allowed us to reach across various sectors, from community health centers to the Native Hawaiian healthcare systems to other larger Ali'i Trust organizations, to really put things on the table, and also to help our Pacific Islander cousins that we can share resources, we can work together to move communities forward. And that's what's very exciting. I think this has allowed for that kind of a environment to be created.
Mahalo. Dr. Samoa, what do you see as opportunities?
Oh, so we have a unique opportunity to catch lightning in a bottle, you know. So one of the things that I am very observant about is that what predisposes a lot of our communities overall is this inability to self-determine our health, you know. And so why do I say this? Because islands who have a lot less resources than us are stopping the pandemic, you know. And why do they do that? Because they can determine what happens to their people, you know, what happens to us. So we don't have that luxury, and we rely on state and public health agencies on the local level to offer that protection. But those deficiencies happen, like I said, they're built into the structure, and they don't reach us when we're suffering from chronic disease. When we have an acute pandemic going on, we are completely invisible. You know, we are completely ignored. And because the self-determination that is required to help protect our communities is not there. So how do we engage ourselves in those essential strategies that need to be implemented for that protection? Well, one of the ways is through this Pacific Islander Community Health Worker Program. I think it's the previous slide. Do we have the previous slide? Oh, the next one, right? The one after that. So somebody had asked a question in the chat room about how do we reach, how do we get our people the services they need if they're already mistrusting of public services? Well, we become the liaison, right? There's a reason why I'm asked constantly to do podcasts. I'm in people's tea groups, I'm in people's Bible study, I'm in people's public bake sales, because my Pacific face allows me access that others do not, you know. And so you understanding that the marginalization of our the services to our people is not new. This is not a new thing for us. This is something we've struggled with for decades, you know, and usually it's on the chronic disease level when we're talking about diabetes and cancer. But in this area, it's crucial to stop the transmission because you need contact tracing. That means you need intimate, in-depth conversation with positive cases in the Pacific Islander community. Contact tracing is the buzzword right now to stop the transmission. It is totally reliant on the person's ability to trust the person that's interviewing them. That is a big problem, right? Because even though the communities have fought to make testing more available in places where our Pacific communities reside, they're not using it. They're not using it because it's still not our face that's providing the service. And so to increase our exposure in that realm, we prompted the counties to let us be the liaison. Let us be the one that does the assessment in regards to how people are coping with a positive diagnosis. So our community health workers are going to be trained to help families develop a family safety plan. Who else in the house needs to be tested? Is there enough food in the house? Do you need financial assistance? Who are the contacts that you've been exposed to that need to be tested as well? You know, and this type of information is more likely to be given when there's a trusted entity on the other end of the phone. That doesn't mean every Pacific Islander community health worker will know each person that is positive. But the network that we're setting up, the faith-based network, as well as the resources network, allows us access to Pacific leaders, faith-based leaders that can help us get into those homes. That helps us. And then the assessment in regards to wraparound services. What good is testing someone if they don't have the proper facilities to quarantine, right? So part of our the overall strategies is to make sure that those of us who live in multi-generational homes where it's crowded and it's really hard to isolate, that those resources are made available. Luckily for us, at least in Southern California, the churches have stepped up and said, we'll be the temporary care facility to help people who are symptomatic with COVID-19, but they're not sick enough to be hospitalized. And so leveraging the community resources that are in place, I think is going to be crucial for us to turn these numbers around. And so we know that this is just another example, right? COVID-19 to me is sort of a historical recurring motif. The viral pandemics that have just really devastated our communities in the past, there's something to be learned about them, right? So the Spanish flu pandemic that wiped out a lot of the Pacific took out about 20% of the country of Samoa. They killed about 1/5 of the Samoans that lived in what was Western Samoa at the time. And a lot of it was because the New Zealand government at the time really made it difficult for the indigenous population to survive the conditions. You know, they didn't provide for adequate resources, and they weren't very protective, and they weren't very good stewards of the community's health. So in that tragedy was the birth of the Samoan sovereignty movement. You know, and so I want us to be really, really clear. I know it looks like that we're running a Pacific Islander party here because, you know, I put up some fancy graphics and I'm showing you how people are working together. But I will tell you, it is not easy. You know, there have been decades of obstacles that keep us from working together. But the devastating impacts COVID-19 has been that Pacific Island communities have been experiencing has pushed us in a place where those walls currently are down, you know, and it forces us in a place where we have to work together or else we're going to continue watching our people die, you know. And so I know there's I've heard some people in Hawaii tell me, well, we don't see it. We don't see the deaths yet. We don't see the numbers super high yet. The point of all of this strategy is to help protect us, not just now, but in the future. When that second and third wave hits, we need to be prepared to protect our people. And so Hawaii, there's obstacles, there are obstacles galore. And I implore you, as somebody who was born and raised in Hawaii, that this is the time for you to put those things aside, and to work together, because we're not going to get through this without each other. Yeah, sorry to take up so much time.
No, point well taken, Dr. Samuel. Mahalo for that. Actually, that's a wonderful to bring this thing to our webinar to a close, and answer some questions. But I want to answer one question right off the bat here, because I saw it come up on the Q&A or the chat, asking whether this is due to structural racism and the colonial powers that has occupied our countries and led to our current circumstances. I think Dr. Samuel's last statement there really speaks to that. Structural racism and discrimination, especially example about Samoa under New Zealand rule. So let's not hide the issue. It is about racism, discrimination. It is about historical mistrust and disrespect that puts us at a disadvantage. But as both panelists have shared, there's a lot of opportunities for us moving forward, coming together as one, and the self-determination issues around our own health and well-being in our communities affords us a great opportunity going forward. With that, I want to turn it over to Stephanie to help us with addressing some of the questions and answers.
Alva, can I make a comment really quick? I agree, and I think one of the things is we need to start moving away from the disparities and the deficits that we know we have. We get it, we know it, but we need to shift the conversations around. And so what are we going to do different? And what is the resiliency that our communities have? Because when we look at our history, our history is very clear about our ability to be resilient. If we weren't resilient, we still wouldn't be here. And so I think that's a strong realization that we need to take as a community, that we need to start shifting that narrative from a deficit based to a resiliency based conversation.
Oh, yes, we do. And I think some of the questions might get to that point and allow us to further elaborate on that. I want to make sure we have some time for the question. Stephanie, what might be the first question for our panelists?
Okay, first question we have, and before I ask that, I do want to apologize. I don't think that we will get to all the questions that have been asked today, but we will get those answers and contact you via email if we don't get to your questions today. But first question is, I would like to know the statistics regarding which ethnicities contracted the virus by community spread. Where can I find this information?
So if you go to the Department of Health's website, they have a COVID-19 page. The only thing that breaks down by counties is the overall numbers of cases confirmed and by deaths. It does not break down any race ethnicity by counties or by communities on any of the islands. And then if you scroll down the page further, that's where it has the breakdown of race and ethnicity that you can see. So that chart or that graph is updated every Friday, I believe at like noon. So you can see that it's only updated weekly, while the overall tracking of cases is updated every day.
I think I don't know if it has community spread versus cases that came into us through visitors or tourists. I do know though, and I think Sheri, you can confirm this, that the reporting of Caucasian ethnic group or racial group in the state's data, it shows also a high rate of infection, but that might be skewed a bit because many of the cases that came in because of tourists or visitors to Hawaii were counted in there, and they just so happened to be Caucasian. Am I correct, Sheri, in assuming that?
Yes, I believe so, Kiave. And then I'll get the link for that question so that we can provide that.
Ray, your folks and Dr. Samoa, do you know about anything, the community spread versus other transmissions?
No, we're lucky to get the data we have. We'd like to break it down even further by Pacific Islander ethnic groups so that we can hone in our efforts, but we're not getting, we're not even getting that information. And so I think one of the opportunities here is this broken data collection system that's kind of, all these different systems that don't really talk to each other that great. That's our opportunity. There was a mention of a Damagi, but there's also Salesforce, a unified data collection system that's mobile and user-friendly that allows for interface with just communities as well as with other advocacy groups. We're long overdue, because when this is over and we're back to our high levels of chronic disease, those systems in place will help with that as well, And so, and it can be activated again when, should another pandemic arise. And so this is why it's really important, you're gonna get tired of me saying self-determination, but this is one of the ways we put things in that helps protect us, and easier communication allows us to protect ourselves better. It helps counties. So how does that happen? Why does it matter? If there's a delay in the data collection and the appropriate resources, it can be catastrophic when it comes to COVID-19. So for instance, when I was diagnosed, it took about 6 days for the county to contact me, 7 days for me to actually talk to somebody from county. In 7 days, I could have affected 100 people, right? So it's really important that when this information gets collected, it goes directly to people who can do something about it. Yeah, that's my pitch.
Mahalo, Dr. Samoa. Good pitch. It took us about 20 years to get disaggregated from the Asian populations. Hopefully it doesn't take another 20 years to disaggregate ourselves to get more accurate counts and represent. Yeah. But, Stephanie, I can actually see a lot of the questions and answers. For the sake of time, Maka, could we go advance the slide to the slide that has the email address for the local Hawaii COVID? I believe is it that one? Or, yeah, this one.
So Kiave, I did want to just update that question about the data. I did answer it for the person in the Q&A, but they do have a picture of the island and colors. So that's probably, and so they can scroll through that page and it'll give them age, gender, all of those things on that Department of Health website.
Thank you very much. And a lot of people are asking about how can they kokua with the efforts here in Hawaii around the response team. So I want to share this slide right now that's up to contact the Papa'olo Lokahi team who is organizing and leading this effort. And there's also been questions around membership and are others involved? I saw a question around that. Yes, Papa'olo Lokahi is the organizing organization, and Dr. Sheri Daniels is the lead organizer and co-lead amongst 3 other members that represent the Native Hawaiian and other Pacific Islander groups. For example, Samoan and our communities from the Micronesia region of the Pacific. We also part of that effort, as she mentioned in her talk, are other organizations to include leaders from our community health centers where they serve a predominantly Pacific Islander population, as well as leaders from our healthcare systems and grassroots organizations such as representatives from some of our homestead communities. And as she mentioned, we welcome, it's an open group if people are willing to kokua and can contribute to this effort. But we want to make it clear it is a PI-led group to make sure that we're being true to our communities and making sure that everything is culturally relevant to our communities.
And just to
Stephanie,
add on to Kiave, just to add on to that, I think there has been asks of us on whether or not we're going to expand this so that we have very clear neighbor island voices. So we've really tried to make sure to have that available. But if we see the need for us to convene sub-teams in counties, because we know that there are very unique issues and wants and needs and successes, that we want to be respectful of that as well, so that we can lend your voice to the bigger pot as well.
Hello, Sheri. Stephanie,
Yeah, so can I just say something real quick? Somebody just had a question whether or not this is mostly a regional, a California consortium. No, it's spread across all of the regions that I mentioned previously. And our first initial call was, I think, April 17th, and it had about 27 people on the call. As of now, there's almost 400 people volunteering there in the effort. And so if there's been an example of Pacific Islanders showing up for each other, here it is.
mahalo. And I think we're probably anticipating the same growth with our local response team as well. So thank you for the heads up. And that does show the strength we have as a community and coming together in this difficult time. Stephanie, is there questions other than the types or nature that we already addressed?
Yeah, let's see. This is one regarding homelessness. So due to high rates of homelessness in our population, our group will be doing COVID testing for Hawaii's homeless. Wondering if you can shed light on the best COVID testing kits for our people, and how do you feel about the emergency use authorizations by FDA?
Wow. Okay, that's quite. That might require another half hour or so. But Dr. Samoa, would you like to take a stab at this really quickly?
The most sensitive is the swab. The RA kits. There's more rapid kits that they're not as sensitive and specific, but it depends on what your resources are. Those tests, if that's, but those swabs are the most expensive and they're the most labor intensive. You have to wait the longest for the results to come back. It requires the full, for someone to be completely gowned up to administer it. And so, yeah, you're right. It all depends on what your resources are, and what you can afford to reach the community you're trying to reach. We do have a testing group. I think my email's on there somewhere, right, Stephanie? So whoever had the question, if you want to reach out to me, I can connect you to our testing group, and they can respond.
We'll definitely get the email, your email contact information out. I know locally too, there's been a group that has also gone out. And Sheri, I can't recall the name. I want to say Premier is in the name.
Yeah, Dr. Miskovich.
Yes.
So, yeah, so here in Hawaii, there's been a lot of drive-through testings, community. So those have been organized through the Premier group. And so we see those available. We know some counties have partnered. The city and county of Honolulu has partnered with the community health centers on doing testing. They just announced a new partnership yesterday with the mayor's debriefing. And so I think there's those opportunities happening. I know there's been some community-led testing sites. And so part of the response team is to actually create a landing page that has a lot of those testing sites available, because people have questions about cost. They have questions about all of those things. They have questions about the antibody tests versus the rapid versus the PCR ones. And so wanting to make sure we provide as much accurate information when we release or go live on the landing page. And so we've been looking at the national folks to give us some guidance on that. But here in Hawaii, there has been the release of the antibody tests a few weeks ago that I think Lieutenant Lieutenant Governor Green talked about. So both clinical labs and diagnostic both do that. And I believe there is a co-pay cost. Insurance does not cover it. So I believe it's around $50, don't quote me, but you still need a doctor's prescription to get that antibody testing in particular.
Thank you, Dr.
Yeah, Miskovich, we're not seeing any data from him. And so I don't even know if they're collecting ethnic data. So, you know, you want to advocate for somebody, tell them to start reporting and collecting ethnic data.
Mahalo.
You know, that's a low hanging fruit there if enough people bug Miskovich to collect that.
We'll do that. We'll do that because I know they're not. But we need to end this because it's going to go off soon. I want to mahalo both of you, Dr. Samoa, Dr. Daniels, for the time, your mana'o, your expertise, your wisdom. Mahalo to the Hawaii Public Health Institute and everyone that made this possible. We'll try to get your questions answered over email over the next couple of weeks, hopefully, if we didn't answer your questions here. So mahalo, everyone.
Mahalo, everyone. Again, as Kiave mentioned, I want to say thank you to our speakers. So to Kiave, Dr. Samoa, and Dr. Daniels for being our trainers today. I want to thank all of you for joining us on Zoom. Mahalo to the HIPHI staff behind the scenes, making sure the webinar ran smoothly. Lastly, please mark your calendars for next week's webinar. We will be joined by Dr. Sarah Park and Dr. Amy Grace. And the topic we will cover next week is Partnership for Contact Tracing Training, a new program by Department of Health and the University of Hawaii. Again, mahalo for joining us today, and we hope to see you next week. Aloha.